This is a presentation for an erythema multiforme case. 40 years old male, his chief complaint painful oral ulceration started 4 days ago with redness and soon after bleeding ulcers. Also lesions on the palm. History. Complaints started 3-4 days ago. Initially started with redness in the oral cavity and over lips. Soon bleeding ulcers and bullae appeared at these sites. Bullae ruptured to form incrustations over lips. Upon exam, general appearance, normal development, nutrition and ambulation noted. Communication normal. Extraoral exam normal facial and scalp tissue. Color of skin and texture normal. TMJ clicking both joints. Lymph nodes normal. Hands, right palm has erythematous lesions. Intraoral exam found dark brown incrustations were present on lips. Lips were edematous and erythema was present around incrustations. Bleeding ulcers were present on dorsum of the tongue, hard palate, buccal mucosa, and gingiva. Few hyperemic papules and macules were also present. Pharyngeal and laryngeal examination was normal. No neck nodes were palpable. A diagnostically significant finding was the presence of two target lesions on the palmar surface of left hand. Other systemic examination was normal. What's our plan? Routine blood test and biopsy was obtained. Routine hematological investigations were within normal range. Fasting ECR was 25 mm in first hour by Wester Green method. Liver function test revealed slightly raised transaminases. Investigations for hepatitis B and C and HIV were negative. Biopsy from the lesions on histopathological examination revealed intracellular edema, liquefaction, degeneration in epithelial layer, dilatation of dermal capillaries, and inflammatory cell infiltrate consisting predominantly of lymphocytes, neutrophils, and eosinophils. Diagnosis: herpes erythema multiforme. Erythema multiforme types. Two types, either minor or major. Minor, mainly a cutaneous disease. Typical and or raised atypical target lesions are the hallmark. Disease involves less than 10% of the body surface area. Lesions are often symmetric in distribution, with a predilection for the extensor surfaces of the extremities. Mucosal involvement is uncommon. When present, only one side is affected, most commonly the mouth. Erythema multiforme minor that only affects the oral mucosa may occasionally arise. What about the major one? The major involves two or more mucous membranes with more variable skin involvement, symmetrically distributed, typical cutaneous target lesions and or atypical raised target lesions are the hallmark. Less than 10% of the body surface area, but more severe than erythema multiforme minor is involved. Oral lesions are usually widespread and severe. Oral manifestations. Erythema multiforme range from tender superficial erythematous and hyperkeratotic plaques to painful deep hemorrhagic bully and erosions. Edema, erythema, macules, swelling, target lesions may be seen on the lip but rarely on the intraoral mucosa. These are the most common associations with erythema multiforme: microorganisms, virus, herpes virus, adenovirus, enteroviruses, hepatitis viruses A, B, and C, HIV, influenza, bacteria, mycoplasma, pneumonia, chlamydia, corynebacterium, diphtheria, fungi, and parasites. Drugs, allopurinol, barbiturates, cancer chemotherapeutic agents, carbamazepine, cephalosporins, non-steroidal anti-inflammatory drugs, penicillins, phenycian, protease inhibitors, food additives or chemicals such as benzoate, nitrobenzene, terpenes, ethanol, immune and other conditions such as graft versus host disease, immunization, inflammatory bowel disease, pregnancy, sarcoidosis, systemic lupus erythematosus. What is the treatment? Oral methyl prednisolone 32 mg a day for 7 days. Refrain from drinking alcohol and smoking. What happened to patient? Patient returned after 7 days. All the mucosal lesions healed and the methyl prednisolone was stopped after tapering over next 7 days, and mouthwashes consisting of local anesthetics and antiseptics were added for symptomatic treatment. This is the end. Thank you.